Dr. Lederman, we are not only Colombia. We have people from most of the country in Latin America.
Oh, okay. Okay. This is
Argentina, Uruguay, Venezuela, Chile.
good. Oh, okay. I didn't realize. I thought it was the Colombian Society meeting. Okay, good.
Yes, all Latin
Excellent.
America.
Excellent. Excellent.
Hola, buenos días.
Ray, estás mutado, ¿no? Sí estás hablando, ¿no?
Sí, no, estoy aquí a tres bandas. Bueno, reciban todos un cordial saludo desde el grupo colombiano de investigación en oncología ginecológica y es un gusto recibirlos esta mañana de hoy. Hoy tenemos como invitado de honor al profesor Jonathan Lederman, quien desde Londres nos va a hablar acerca de cómo escoger la mejor terapia de mantenimiento en cáncer de ovario avanzado. Es un orgullo y un honor para todos los que estamos aquí tener al doctor Lederman, un profesor de talla internacional. Dr. Lederman, please receive our warm welcome, and we are really honored to have you here, and we are going to learn a lot this morning. Welcome.
Thank you. Thank you very much for the introduction, and thank you very much for the invitation to speak to you. So I've been asked to talk about choosing the best maintenance therapy for newly diagnosed advanced ovarian cancer. These are my disclosures. So if we look at the timelines going back over 20 years, what you can see is that really in the early part of this century, we were at a period where there had been little change in the outcome of treatment of women with advanced ovarian cancer. All the trials with different chemotherapies had really resulted in the platinum taxane backbone as being the most effective treatment for ovarian cancer. About 10 years or so ago, things began to change with the introduction of bevacizumab targeting circulating VEGF-A. But the big change occurred really more recently as PARP inhibitors, which had been used and developed in the treatment of recurrent ovarian cancer, became incorporated into the frontline treatment. And it's really that I'm going to speak about in the next 30 minutes. Sorry. So here you can see the situation really, the early part of the 21st century with the introduction of bevacizumab, and you can see on the left-hand side that the use of bevacizumab with chemotherapy and then as maintenance leads to a small but significant improvement in the progression-free survival, but no improvement in the overall survival on the right-hand side. And if you summarize really the work that was done here, it's an order of about 4 months improvement in progression-free survival. The median time to progression in this GOG 218 trial was still around 12 months, and the median survival is 3.5 years. And these are really quite difficult statistics. They're not really good results in terms of our patients. But the situation has, as I mentioned earlier, really changed considerably as PARP inhibitors became incorporated initially in the treatment of recurrent ovarian cancer, but now more recently in the frontline setting. And so I'm just going to give you a very brief summary of the background to the introduction of PARP inhibitors, which goes back around about to 2005 with two very important papers that were published here in Cell Lines, showing that if you use a PARP inhibitor in a cell line that is homozygously deficient here in the BRCA2 gene, you can see that the addition of a PARP inhibitor leads to an almost 1,000-fold increase sensitivity to the cell in terms of cell death. And what we now know, of course, is that the PARP enzyme is activated by breaks in DNA repair. If you inhibit that with a PARP inhibitor, you stop that repair process, and it leads to a double-strand break in DNA, which is a much harder lesion to repair. But in a normal cell, that is repaired by a process called homologous recombination, bringing the two ends of DNA together. But in cells that are deficient in homologous recombination repair, typically cells with a BRCA mutation, then you get error-prone repair, accumulation of DNA damage and cell death. And that's how PARP inhibitors work. And we looked at this some years ago, exploring the concept of maintenance therapy with olaparib in patients with recurrent ovarian cancer who responded to platinum-based therapy. And we selected this group of patients because we knew that response to platinum was some sort of surrogate for a benefit from a PARP inhibitor. And so these were patients with or without BRCA mutations who then were given either maintenance olaparib or placebo. And you can see the big difference in progression-free survival with maintenance olaparib in this setting. And when we look more closely at the patients, some of whom had a BRCA mutation and others that were BRCA wild type, we saw the effect of maintenance olaparib even greater in those with a BRCA mutation. You can see in the top panel on the right the hazard ratio of 0.18, but even a significant improvement in the BRCA wild type patients on the bottom panel on the right with a hazard ratio of 0.54. So this really set the scene for PARP inhibitors maintenance in patients with recurrent ovarian cancer. So we know that BRCA, of course, BRCA mutations are key in terms of this inability to repair double-strand breaks in DNA. But in addition to cells that have BRCA mutations or alterations in the function of the BRCA gene, there are a number of other factors that affect the ability of the cell to repair double-strand break damage by homologous recombination, to the point that in high-grade serous ovarian cancer, approximately 25% of patients have some abnormality in the BRCA genes, whether it's germline or somatic mutation or methylation of the BRCA1 promoter. And another 25% have other non-BRCA related effects that impair homologous recombination. There are other genes such as the RAD51 group of genes that can be mutated or methylated, but there are a number of other processes, some of which we understand and others less so, that give rise to this phenotype of homologous recombination deficiency in approximately 50% of patients with high-grade serous ovarian cancer. But the big question, of course, was whether or not we could move the maintenance with PARP inhibitors from the recurrent setting into the frontline setting, where we know, as I showed you earlier, that although you get good responses and some improvement in progression-free survival with bevacizumab, patients still have residual disease at the end of their treatment phase, and that will grow back in the majority of patients. So the question is whether putting in a PARP inhibitor at that point at the end of chemotherapy can allow suppression of the growth or even eradication of resistant clones of cells. And this was first looked at in the SOLO-1 trial, a maintenance trial with olaparib in women with BRCA-mutated ovarian cancer. So these are women with stage 3 or 4 disease, known to have a BRCA mutation, who undergo surgery and chemotherapy. And those patients who are in response at the end of that treatment period were then randomized to either maintenance olaparib or placebo. and this was given for up to 2 years unless there was disease progression, and the primary endpoint was progression-free survival. Now, in that group of patients in SOLO-1, there were 17% of patients with stage 4 disease. Nearly a quarter of patients had residual disease after primary surgery, and in fact, 18% had residual disease after interval debulking surgery. But at the end of that treatment period, 82% were in complete clinical response, but 18% of patients had a partial response only at the time they went into the maintenance phase. So what we saw in the SOLO-1 trial here, treatment given for 2 years and then stopped, was this big difference emerging quite early in the patients receiving maintenance olaparib. And you can see here arrowed that those patients who received placebo, really within the first 6 months of that maintenance phase, about 15% of those patients were already progressing. These are women with a BRCA mutation, and they are not doing well on maintenance therapy. So this early difference was seen. The treatment was stopped at 2 years. And when we look at the longer term follow-up of these patients, looking out now to 5 years, you can see this significant sustained benefit in progression-free survival in patients who receive maintenance olaparib. And you can see the hazard ratio, which is a measure of that difference, as 0.33. And at 5 years, if you take a snapshot analysis, 48% of patients are progression-free on olaparib, whilst only 21% of patients are progression-free on the placebo. So this was really a big step forward in the frontline treatment of patients with a BRCA mutation. But what about the side effects of this drug? Well, we've already known quite a lot about the PARP inhibitors from their use in recurrent ovarian cancer, and the side effect profile was very similar in the frontline setting. The key side effects are either the hematological problems, neutropenia, anemia, and thrombocytopenia. The non-hematological side effects, principally fatigue and nausea, with some of the drugs such as niraparib, as you'll see in a minute, hypertension can be a problem. And there are these rare but important side effects that we need to be aware of, such as the development of myelodysplasia and acute myeloid leukemia, and rarely a pneumonitis. But if you look at the SOLO-1 pattern of adverse events on the left-hand side, you can see that although nausea and fatigue and anemia were present, for most of these patients, it was low grade, grade 1 or grade 2. Anemia perhaps being the one where you saw 21% of patients with a higher grade anemia. And looking at the placebo, you can see that that was also not without side effects, just really emphasizing the importance of doing these placebo-controlled studies. But most of the patients were able to receive the full dose of treatment. You can see on the right-hand side that some patients did need a dose reduction. That was often the first 6 months of therapy, and after that, the dose remained pretty stable for an individual. And most patients completed treatment. Only around about 12% had to stop because of toxicity. We now have the results of six trials of different PARP inhibitors in the frontline setting, given as maintenance in patients with advanced ovarian cancer. Most of these are monotherapy, with the exception of PAOLA-1 that I will speak to in a minute, which includes olaparib and bevacizumab. And the important point here is that all of these trials were positive. They met their primary endpoint, as you can see on the bottom row, with very respectable hazard ratios showing benefits of PARP maintenance across a diverse group of patients, some with BRCA mutations and some without BRCA mutations. So here is just a snapshot, not to compare the differences between the trials, but just to give you a visual impression of the effect of the PARP inhibitors in this BRCA mutated population, whether it's olaparib with SOLO-1, niraparib with the PRIMA trial, rucaparib with the Athena mono trial, or indeed the PAOLA-1 patients who received that combination of olaparib and bevacizumab. So clearly a benefit in terms of progression-free survival. But the real question here is whether the benefit of these patients is seen not only in the BRCA mutated patients, but whether it can extend, as it did in the recurrent disease population, to BRCA wild type populations. And for that, I'm going to review now two all-comer population trials. So these took patients with BRCA or without BRCA mutations. One was the PRIMA trial, in which niraparib was given as maintenance after the primary chemotherapy and surgery. And the second is the PAOLA-1 study, in which patients received chemotherapy and bevacizumab. And then at the end of that chemotherapy phase, they either had olaparib added to the bevacizumab or placebo added to the bevacizumab. So if we look at these trials, we have to understand, of course, what these BRCA wild type patients are and whether they have this homologous recombination deficiency. And certainly when these trials were done, the best way of looking for homologous recombination deficiency was through a test called the Myriad MyChoice assay, which looked at the degree of genomic instability largely through the loss of heterozygosity that comes about from genomic scarring in cells that have this HR deficiency, plus some other factors such as telomeric imbalance and large-scale state transitions, which all put together gave a score given by Myriad out of 100, which gave this degree of genomic instability. So we had a group of patients who clearly had a mutation, BRCA mutation, either somatic or germline, and then we had this group of patients with genomic instability, and those with the high score were predicted to have a likelihood of good response to a PARP inhibitor because of HR deficiency. And when we looked in the two trials, the PRIMA and the PAOLA studies, you can see that the division of HR deficiency, whether it's through BRCA or BRCA wild type, was approximately 50%, as one might have predicted, and as I showed you earlier from the Cancer Genome Atlas studies. And this was made up of either a BRCA mutation tumor or germline, or this BRCA wild type HRD positive grouping. So when we look, for example, at the PRIMA study and look at the stratified analysis as to HRD positive versus HRD negative, you can see that amongst the HRD positives, we have, of course, those with a BRCA mutation and those that are BRCA wild type. That was 30-20 split out of the 51% of patients. And what you can see is a positive effect of niraparib in both of these groups, with a difference in the median progression-free survival of around about 11 to 11.5 months, hazard ratios 0.4, 0.5. So really very favorable effect. And then if you look in the BRCA, in the HRD negative group, as by the Myriad assay in this niraparib study, there was a difference, 0.68 was the hazard ratio, but it was only a 2.7 month difference in progression-free survival. Similarly with the PAOLA-1, adding olaparib to bevacizumab, again splitting it by HRD positive and HRD negative. This was an exploratory analysis, and you can see positive effects in both of those HRD positive groups. Again, a 19.5 months difference in the median in the BRCA mutated group, and 11.5 month difference in the median in those patients who are BRCA wild type. But here in this trial, the effect of olaparib and bevacizumab in the HRD negative or unknown group did not show any difference at all, the hazard ratio of 0.92. But the crucial question for patients receiving frontline treatment is whether this improvement in progression-free survival translates to an improvement in overall survival. We're now beginning to see the emergence of overall survival data. The SOLO-1 data were the first to be presented. The final endpoint of this trial has not yet been reached. It's defined as a certain number of events, death events, before the analysis can be done. So this presentation and publication was a descriptive analysis taken at 7 years of follow-up. And what you can see here is this difference in survival in those patients receiving olaparib is maintained and actually after 5 years really flattens off. So between 5 years and 7 years, there are very few deaths occurring. So this really gives one encouragement that patients with a BRCA mutation who are treated with olaparib, actually some of these patients might be cured by the addition of olaparib. You can see the control arm here. Of course, that includes the fact that 44% of patients crossed over to a PARP inhibitor when they had a relapse. So that improves, of course, the control arm survival, but it still lags behind. There's about a 20% difference in the survival at 7 years. These are patients with stage 3 and stage 4 ovarian cancer. In the PAOLA-1 final analysis with bevacizumab and olaparib, on the intention to treat, there's no difference that you can see here, but it's amongst the patients who've got HR deficiency, as demonstrated by the Myriad assay, that show this 17% difference in survival at 5 years with a hazard ratio of 0.62. So looking at this HRD population in a little bit more detail, as we did earlier with the progression-free survival, you can see it's made up of those with a BRCA mutation, those that are HRD positive without a BRCA mutation, and of course, that HRD negative population. And here you can see in the BRCA mutated group, data that are very similar to what we saw with SOLO-1. There's 20% difference at 5 years. It's a 10% difference thereabouts at 5 years in the HRD positive patients who are not BRCA mutated, and as expected, no benefit in the HRD negative group. Well, what about the long-term toxicity? And I'm focused here particularly on the MDS and AML in these studies. We now have that 7-year follow-up with SOLO-1, and it's pleasing to see that the MDS AML rates have not increased since the primary analysis. It's less than 2% of patients. We know that patients with a BRCA mutation tend to have slightly higher risks of AML anyway. But in the the PAOLA-1 study with the final analysis, again, it's under 2% of patients have MDS, and the pneumonitis in both of those trials, again, less than 2%. So it's reassuring that there is no increase in the long-term toxicity with these drugs. So one of the big questions that has arisen out of the results that we've seen, particularly from the PAOLA-1 study, is, what is the contribution, if any, of bevacizumab to the results? We haven't yet seen the prima data survival, but we will see that next month at ESMO. So I think that will be very informative in thinking about how, particularly amongst patients who are BRCA wild type, we might treat or might use PARP inhibitors. But if we go back to the bevacizumab trials that I showed you earlier here, showing you not only the 218, but also the ICON-7 trial, we can see in then these exploratory analyses for overall survival that patients who were deemed to be at high risk of recurrence, stage 4 patients or those with residual disease at the end of surgery, actually had a survival benefit. It's an exploratory retrospective analysis, but it did seem that certainly in those high-risk patients, there was a survival effect of bevacizumab. And I think that has influenced our thinking a lot in terms of which patients we offer bevacizumab to. These are some recent real-world data of patients treated with bevacizumab or not. And you can see in this study, this real-world study, that those patients who received bevacizumab, these are high-risk patients, had a better outcome than those patients that did not. So I think that supports, the general drift of thinking that certainly we should be using bevacizumab in patients who are at high risk of recurrence. Historically, many of us have not used bevacizumab in the lower risk setting, but it's made us think again, seeing the results of PAOLA-1. And here you can see in the patients with tumor BRCA mutation, the effect of bevacizumab, well, not the effect, you can see the results, I should say, in the high-risk patients, those stage 4 patients, or those patients with residual disease, and in the low-risk patients. Now, what was interesting about the low-risk patients, which is the bottom panel, is this very big difference, apparent difference, in patients receiving olaparib and bevacizumab compared to placebo and bevacizumab. And that is unusual, because we would have not have thought that the bevacizumab here would have had much effect. And it may be that this is just a spurious finding, small numbers of patients, but nevertheless, it does raise that question as to whether we should perhaps be considering bevacizumab in all groups of patients. Here you can see in the HRD positive group in that trial, very similar data showing this remarkably good outcome in the lower risk population of patients who received olaparib and bevacizumab. But of course, without a control arm of olaparib alone, it's very difficult to know what the effect of bevacizumab was in PAOLA-1. So in order to try and get a better idea of this propensity matched analysis was done, comparing patients in SOLO-1 who had a BRCA mutation to the subset of patients in PAOLA-1 who also had a BRCA mutation, because if the two populations could be matched, albeit retrospectively, then we might be able to answer the question as to what effect bevacizumab might have had on the use of olaparib. So this propensity matched analysis took account of the fact that in these two trials, there were different numbers of patients with known prognostic factors, such as percentage with stage 4, the percentage with residual macroscopic disease, and the percentage of patients who were in only a partial response. And so the populations were adjusted so that equal numbers, if you like, of patients across those prognostic factors were then included in this propensity matched analysis. And when you do that, with all the caveats of that matching and the retrospective nature of this, what you see is that those patients who received olaparib and bevacizumab appeared to do better than those who received olaparib alone. However, you can also see that the confidence intervals, which were the shaded areas on these curves, are wide and overlapping. So I think we have to interpret these data with caution, and it really, needs us to understand whether or not bevacizumab does have a role by looking at prospective randomized trials. And there are 3 now that are being done or have been done, not yet presented, which should answer the question whether or not the addition of bevacizumab to a PARP inhibitor, whether it's niraparib or rucaparib, actually improves the outcome. So we will await the results of these 3 trials with interest. But having said all that, there's clearly a role for PARP inhibitors either on their own or together with bevacizumab in the treatment of patients with advanced stage 3 or 4 ovarian cancer. And this is a summary taken from the recently published ESMO guidelines, clinical practice guidelines for ovarian cancer, that was published in the Annals of Oncology last year, where we separate patients into high risk and low risk, and whether or not they have neoadjuvant chemotherapy or primary cytoreductive therapy. But central to this is now the testing of all of these patients for germline or somatic mutations in the BRCA gene and HRD testing, so that we can divide patients into those 3 categories: BRCA mutated, BRCA wild type HRD positive, and BRCA wild type HRD negative, and offer these patients PARP inhibitors or bevacizumab accordingly. If we go back to the SOLO-1 data and look at this exploratory analysis of time to first subsequent treatment, which is actually a question that patients always ask us in the clinic: how long will it be, doctor, before I have to go back onto chemotherapy? And what we can say from the SOLO-1 studies is that in the olaparib arm, 45% of patients who were still alive at 7 years had yet to receive any subsequent therapy, which I think, is really an encouraging statistic for our patients. Having said that, there are patients on olaparib who clearly are progressing during that first 2 years of treatment, about 22% of patients, and a further 20% who require treatment by 4 years. So that's from stopping the olaparib for the next 2 years. Another 20% of patients have a progression. But after 4 years, you can see the curves are really flattening off, and there are really very few progressions between 4 and 7 years, which again is very encouraging for our patients. But having said that, there is more work that needs to be done because we have to try and improve on these data. And also we have to improve on the results of the PARP inhibitors in the HRD negative populations. I showed you the PRIMA data earlier on. The Athena data with rucaparib shows similar results in terms of the hazard ratio. They are benefits, but they're short-lived benefits, and we saw no benefit with the addition of bevacizumab and olaparib in the PAOLA-1 study. So more work is certainly needed in this subgroup, which of course represents about 50% of our patients. So what's going on at the moment to try and improve on the outcome? Well, there are 4 studies, randomized big studies, combining not only PARP inhibitors, but PARP inhibitors with immune checkpoint inhibitors. And I don't have time to go into the background rationale for that, but there are preclinical data to suggest that a positive interaction can be seen when you combine an immune checkpoint inhibitor with a PARP inhibitor. Of these studies, only the duo, the first one with durvalumab and olaparib, has been presented. We're waiting the results of all the other studies to come soon. The duo complex design chemotherapy with bevacizumab, so a sort of standard type of approach, adding in durvalumab or not, and then adding in olaparib in the bottom panel, so that the bottom panel receives maintenance olaparib, maintenance durvalumab, maintenance bevacizumab, and is compared primarily with a control arm, which is just chemotherapy and bevacizumab. The arm 2 contains bevacizumab and durvalumab, but the main analysis was arm 1 versus arm 3, with an exploratory analysis of arm 2 versus arm 1. And what you can see here in this group of patients who were non-BRCA mutated, I think that's important to emphasize. This is already dealing with a slightly less good population, but there were some who had HRD positive tumors. And you can see here in the HRD positive group, the arm 3 of the 3 drugs perform better than the other 2 arms. Now, it's difficult to know what the individual contributions of durvalumab and olaparib are in this study because there is no arm that looks at olaparib alone. And that is a big problem for the duo study. If you look at an exploratory way between arm 1 and arm 2, the gray and the blue, there's very little difference between them, suggesting that actually durvalumab on its own is probably not adding much. So it's either the combination with olaparib or olaparib on its own that's doing it. But we nevertheless saw in arm 3 this benefit, not only in the HRD positive, but was also seen in the intention to treat analysis. And this is the updated unstratified subgroup analysis of the patients who are HRD negative. So this is the worst group of patients, if you like. And here too, we saw in arm 3, the combination of durvalumab and olaparib was better than the gray arm 1 of bevacizumab alone. But again, begs the question, to what extent is this olaparib or the combination of olaparib and durvalumab? At the moment, in the interim and overall survival, there is no difference. But having said that, looking at the progression-free survival here, the median progression-free survival is 21 months. And that is a good outcome in this group of patients with ovarian cancer. So to summarize the data that I've just presented, over really the last few years, we've seen significant improvements in progression-free survival and the long-term survival in patients with BRCA-mutated ovarian cancers using either olaparib alone or olaparib added to bevacizumab. We've also seen significant benefits in the BRCA wild type, particularly the HRD positive subgroup, with the addition of bevacizumab to olaparib, or with niraparib on its own, or with rucaparib on its own. The 5-year overall survival improvements seen with olaparib and bevacizumab are a benefit across both low and high risk subgroups, raising the question as to whether bevacizumab really is important in both of these. But until we have the prospective studies, we don't know what the individual components of treatment are. Olaparib is a well-tolerated drug with manageable side effects. I'm sure we will see the long-term side effects of niraparib when the prima data are presented next month at ESMO. But really, as a result of all these studies, testing now for a BRCA mutation and for tumor HRD should be incorporated into the standard evaluation of newly diagnosed ovarian cancer. So with that, I will stop and thank you very much for listening.
Thank you, Dr. Lederman, for this wonderful presentation. I think that maybe someone has any question for you. ¿Alguien tiene alguna pregunta?
I have one.
Adelante, Dr. Pierre.
Dr. Lederman, this is a patient, stage 4, with liver disease, primary surgery, with L0 surgery, yes?
Sorry, I didn't. You broke up a little bit. Can you say that again, please?
Stage 4 patient.
Yes.
Primary surgery.
Yes.
Complete primary surgery with liver disease, resected. L0 surgery. BRCA negative, HRD positive. What you will give to this patient for maintenance?
Right. I mean, I think that you know, it was the stage 4 patients. Admittedly, it was a retrospective analysis with bevacizumab, but it was the stage 4 patients that seemed to have this small but definite survival benefit when you use bevacizumab. So in those patients, I would use bevacizumab if there was no contraindication to it, and because that patient is HRD positive, I would then add in olaparib. So that would be the, you know, even though she had a complete resection, the fact that you know, there was a liver metastasis puts her into a worse prognostic group, and so I would use the combination of bevacizumab and olaparib.
The same patient.
Yes.
Interval cytoreduction after neoadjuvant, the same patient. Interval cytoreduction, incomplete cytoreduction after neoadjuvant. BRCA negative, HRD positive.
Yes.
It triggered neoadjuvant, interval surgery, incomplete with residual disease. It's a very high risk patient.
Yes.
And what would you?
Well, again, I mean, again, if there was no, because as you just said, she's a high-risk patient because she's got residual disease after interval cytoreductive surgery. So again, if there was no contraindication to using the bevacizumab, I would start the bevacizumab. We don't start it on the cycle 4. We would wait, you know, a bit longer from recovery to surgery, start it on cycle 5, 6, and then continue as maintenance and add in the olaparib because she's HRD positive.
The last question. Kellim score is murder in this question, in the last question, Kellim score?
Okay, I mean, I didn't speak about the Kellim scores. You know, that we just didn't have time for that. Look, I think the Kellim scores are interesting. You know, I think they perhaps need more prospective validation, and that's going on at the moment in terms of whether or not you should be, you know, using bevacizumab. But I mean, I think it just gives you an indication of the patients who are, you know, less chemoresponsive, and it's those patients who really benefit most from the addition of bevacizumab. So yeah, I think the Kellim scores are helpful in making those decisions. I think we need more prospective data to sort of firm that up. But I mean, you know, we're sort of doing that anyway. Before Kellim came along, we were looking at the levels of CA125. We were eyeballing the rate of fall of CA125, and we were making clinical judgments about this patient's, you know, not that chemosensitive. We should probably be adding in bevacizumab. I think the Kellim scores are just giving us a sort of more secure way of doing it, and I think, you know, they will reinforce what we're already doing.
I have another question, Dr. Letterman. For what patients you wouldn't use bevacizumab? For which patients are you completely sure that we will not derive any benefit from bevacizumab?
Okay, well, so there are two parts to the question. I mean, one is which I would not use bevacizumab because of the risk of bevacizumab, and then those patients that I would not use it because I don't think that there's going to be much benefit. Okay, so in terms of the risk, the thing that we worry most about is the risk of bowel perforation. It's small, but it's there. And it seems to be greatest in those patients that have particularly rectosigmoid serosal disease. But if there was generalized miliary serosal disease, at the time of laparotomy, which wasn't resected, then I would be a bit nervous about using bevacizumab. Having said that, when we used bevacizumab in the ICON-8B trial, which we presented last October at ESGO, it's not yet published, but it was presented at the ESGO meeting in Istanbul. A large percentage of those patients were given bevacizumab in the neoadjuvant setting when the disease burden is high. And actually, we had a very small number of patients who developed fistulae or perforation. So it may be that we're just making better judgments about which patients should or should not have bevacizumab. To answer the second bit of your question, where do I think it's perhaps not worthwhile using bevacizumab? So notwithstanding the data that I showed you in Paola 1 of the low risk and the high risk patients and this huge benefit seemingly in the low risk of olaparib and bevacizumab, we don't know, as I've said, what contribution the bevacizumab made to that, whether it was just olaparib in a low risk population was doing extremely well. But my practice has been not to use bevacizumab in those patients who are low risk. That is to say, those patients who've had stage 3 disease, primary cytoreductive surgery, no residual disease at all. If they are HRD positive, then or BRCA positive, then I would use, niraparib if they're BRCA wild type. I'd use olaparib or niraparib if they were BRCA mutated. So I wouldn't routinely use bevacizumab in all of those patients. Okay. Does that help your answer?
Sure. Thank you.
Yeah,
and when you choose bevacizumab, what dosing are you using and for how long?
Yeah. So I mean, there's a sort of peculiar thing in the UK. Well, it's not actually entirely in the UK. There are some countries in Europe, including the UK, where our general use of bevacizumab has historically been 7.5 milligrams per kilogram every 3 weeks, which was the dose from the ICON-7 trial, which was incidentally the first to show that subgroup analysis of overall survival benefit in the high-risk group. So at the time that bevacizumab was first made available, it was extremely expensive, and we had the data on the ICON-7, and so we adopted this 7.5 milligrams. And there are a few other countries in Europe that have done the same. Others have gone for the labeled dose, which is 15 milligrams per kilogram. When the Paola 1 data came along, it was all with 15 milligrams per kilogram. There are no data in 7.5 milligrams per kilogram in Paola 1. And so when that was approved in the UK, we used the 15 milligrams per kilogram. So we're in this sort of slightly strange situation where we start off our patient on bevacizumab because, as Dr. Pierre was, saying, high-risk patients, all the rest of it, we're going to give those patients bevacizumab, and we start at 7.5 milligrams. And then she gets the result of the HRD testing, and she's HRD positive, comes to the end of chemotherapy. We add in olaparib, and we increase the dose of bevacizumab to 15 milligrams per kilogram, because that's what the label says. So we're in a sort of slightly strange situation. HRD negative patient, where we made a decision not to give a PARP inhibitor, we would just give bevacizumab. we will give 7.5 milligrams of bevacizumab. But that's not unique. It's not unique to the UK. You'll get other countries will do the same, but there are also other countries which will just only use 15 milligrams per kilogram. And of course, it has to be said that the price of bevacizumab has fallen considerably now globally. So these sorts of decisions of 7.5 and 15 milligrams are less important financially. I think, though, that having said that, the incidence of hypertension, the incidence of proteinuria is less with 7.5. And just with monotherapy, we really don't have any data to suggest it's inferior at all to 15. But we don't, on the other hand, have any data of 7.5 with a PARP inhibitor.
Thank you. Thank you.
I have one more question. We have done 4 questions, and you have not mentioned immunotherapy like duo or steady. In which patient will you give duo or scheme?
So the question of when will we add durvalumab? Is that what your question?
Yes.
Yeah. Well, I mean, the first thing is that we don't in Europe have a label for durvalumab and olaparib in ovarian cancer. It's coming in endometrial cancer, but that's a different topic. But we don't have that labeled. So at the moment, we have no access to giving durvalumab and olaparib to those patients. I think the jury is still out as to whether or not the benefit that we're seeing in that triplet arm, in arm 3 in Duo-O, is really the combination of durvalumab and olaparib, or whether you'd get the same result with olaparib alone, which of course was not done in the trial. And that's the crucial question. Now, PAOLA-1 showed no benefit of olaparib and bevacizumab in the HRD negative group. So how do you explain that the olaparib, bevacizumab, and durvalumab showed a benefit in that HRD negative group? Well, it's possible that the negative difference you saw in PAOLA-1 just happened by chance, and that olaparib can produce some effects in the same way that niraparib and rucaparib in the Athena and the Prima studies showed a small benefit in the HRD positive group. On the other hand, the pattern of the curve, the PFS curve in Duo-O is different from the pattern of the curve in PAOLA-1, HRD negative, and indeed in the Athena mono trial, which then raises the question as to whether or not the durvalumab is having an effect. It's whether it's really sort of elongating the progression-free survival curve, because the shape looks different. We are going to have to wait till the overall survival data come before we can really, I think, draw conclusions about that Duo study. And I think when we start to see the results of the Key Link and the first trial, and indeed the Athena mono nivolumab trial, we will then get a feeling as to whether or not this combination of PARP inhibitor and checkpoint inhibitor actually are additive. On that note, just a final comment. The first trial, which is the next one, I think, to report, is looking at niraparib versus niraparib plus dostarlimab. So here, that's the only trial where we will see single PARP versus PARP combo. So that's going to be key. And if that trial shows that benefit of PARP plus checkpoint inhibitor, then you start to think, well, maybe there was something in the Duo-O that was real.
Very interesting. The other question is it's about toxicity, MDS. If you see MDS in SOLO2 is higher than SOLO1,
yes.
Do you think chemotherapy is more, platinum is more than PARP inhibitor?
So that's a very good question. So there are two big differences between SOLO2 and SOLO1. The first is that the patients have had multiple lines of chemotherapy. And we know that in patients with a inherited BRCA mutation, the risk of MDS-AML is anyway above the general population, is increased by having cytotoxic chemotherapy and, you know, a number of lines of cytotoxic chemotherapy. And then the third is that in SOLO2, treatment was given until progression, whereas it was capped at 2 years in PAOLA-1 and in SOLO-1. So the question there is, you know, is this prolonged therapy having a detrimental effect on MDS and AML? And we don't yet know that for sure, but certainly when you look at the MDS rates in SOLO2, at the 3 analyses that were done, by the time you get to the mature analysis of SOLO2, the rates were going up. More patients weren't going on the trial, they were on for longer, and the follow-up was for longer. So there may be an effect of duration. We're trying to get a handle on that retrospectively at the moment. It's quite difficult because we know that some patients are treated for many years with recurrent disease, are treated for many years with PARP inhibitors. And so what we're trying to do globally, a group of us, is to collect data on patients. These are not patients who are necessarily in clinical trials, but patients who've been on PARP inhibitors for 5 or more years. What's happening to them? How long are they staying on? Why are they coming off? What are their, you know, rates of MDS-AML? Just to try and build up effectively a real-world database to try and answer some of these questions, because, you know, it's a concern that perhaps, you know, we should not be going on for too long with these patients. But on the other hand, you know, for those of us who've been in this field for a long time, you know, I've got patients who've been on olaparib for 8 years, you know, who are very well. To ask them whether they want to come off, and they'll say absolutely not. You know, I've been well with my recurrent ovarian cancer for 8 years. I don't want to stop. So we don't know the answer to the question.
Yes, like in the study 19. In the study 19, a lot of patients had olaparib for a lot.
Sure. I mean, certainly when we published the study 19 data, which are the oldest data, you know, we had about 12% of patients still taking olaparib for 6 or more years, you know, 12%. I mean, these are women with recurrent ovarian cancer who've had multiple recurrences, and not all of those patients taking it for 6 years were BRCA patients. There were some non-BRCA patients. So, you know, you say to those patients, you know, this is your 4th recurrence, you're now 6 years out, do you want to stop olaparib? No, thank you. And, you know, so we have to talk to them about the risks of MDS-AML. And the thing is, we don't really know whether the risk increases year on year. And that's why we need to try and get more information from the real world data.
Yes. No sé, ¿alguien más tiene pregunta? I have one question. I have one more question. It is about testing, genetic testing. How you proceed? You do my germinal first, or you do somatic first?
Yeah, so that's a very good question. What we do in the UK, and I think a lot of European countries are doing this now too, is we're testing everything at the outset. You know, so we talk to patients. First of all, we don't refer to geneticists. We do what's called mainstream testing. So we give the patients the information, we take the consent, and we do the germline and the somatic testing all at the same time, and the HRD analysis all at the same time. Because if we just did the tumor testing, we would then not know whether the patient had a germline or somatic mutation. And we do need to know that from the point of view of then counseling her in relation to the rest of her family and her risks of breast cancer and so forth. So we do need to know the germline status. We're actually, although we don't have necessarily different treatments, we're doing a panel of genes now, a 14 gene panel for germline, which includes, you know, CHEK1, RAD51, C and D, and so on and so forth. You know, although that doesn't affect our treatment options, but, you know, we're getting just a better handle on the risks, the genetic risks related to ovarian cancer. I've not had a single patient who has turned down germline testing. it's really rare. When you give the patients the information up front, why you're doing this test, what are the potential opportunities in terms of treatment if you're HRD positive or BRCA, have a BRCA mutation, patients will jump to that. So it's not been an issue. The funding, was quite expensive to begin with. The germline testing prices have come right down. We in the UK have centralization of genetic hubs around the country. We've got 9 centers in the whole of the UK that do the testing, which again brings the price down because the volume goes up. So the blood and the tumor gets sent to these genomic hub centers that will do all the testing for us. The HRD testing is more expensive, and that has been an issue. We're lucky to get funding initially supported by AstraZeneca in the UK. But what is now appearing are a number of other non-myriad tests, which are, as effective in terms of defining HRD positivity versus negativity. And that's driving the price down. So the price of HRD testing is falling. It's not yet as low as we'd like it to be, but it is falling, and I'm sure it will continue to fall further.
And another question, do you think that there is a lot of surgery in the room? Do you think that in the future, the surgery will be made based on BRCA status?
No, I don't think so. I mean, there is still a debate going on as to whether or not neoadjuvant chemotherapy and primary cytoreductive surgery are equivalent, whether you can toss a coin and decide. And the camps are divided into those that say it doesn't matter what you do, to those that say, no, you should make every effort wherever possible to do primary cytoreductive surgery. So we'll get a handle on that with the results of the TRUST trial, which is completed, which was done in specialized centers around Europe that were able to undertake radical surgery. And the patients were randomized to either that radical initial surgery or neoadjuvant surgery, neoadjuvant treatment. And we will see. But I still think my gut feeling is, I may be wrong, proved wrong with the results of the TRUST trial, but my gut feeling is that surgery is still a very important component of treatment. And my instinctive feeling is that primary surgery should be done wherever possible. I'm not a surgeon, by the way, I'm a medical oncologist, but primary surgery should be done wherever possible because it sets up the patient to have the best outcome. That is my gut feeling. But the evidence out there at the moment is, there's a lot of debate, as I'm sure you well know, in relation to primary surgery versus neoadjuvant chemotherapy.
I have said before, we have a lot of surgery in the room. But you spoke about the TRUST trial. You think that the TRUST trial will be positive or will be negative?
I have no idea. Look, I would like to think it's going to be positive in favor of primary surgery, because that was sort of bear out my hypothesis, my thinking, my gut feelings. But if I'm proven wrong that it's absolutely identical, well, we'll have to think again. But here, the good thing about the TRUST trial is, it took centers that were dedicated and approved as radical surgery centers, because there's always the question in all of those other trials of neoadjuvant chemotherapy, whether there was less surgical effort in the patients going through primary surgery, because the progression-free survival in all of those trials, whether it's the EORTC trial, whether it's the UK chorus trial, whether it's whichever the trial, the Japanese trial, in all of those patients, the median progression-free survival was considerably lower than it was in trials where patients had primary cytoreductive surgery. Now, you may say, well, that's just patient selection, But what's happened, of course, is, and in our country, is that surgeons have taken the data from the EORTC trial or chorus trial and said, there's no difference between primary surgery and neoadjuvant chemotherapy. So all my patients are going to have neoadjuvant chemotherapy. It's much easier. I don't have to rush to get them to the operation. And, you know, so they're making a jump, you know, which may include patients who would actually do better with primary cytoreductive surgery. So we have to be very, very careful, I think. And, you know, we need to see what the results of the TRUST trial are. We need to see what the median progression-free survival of those patients is, you know, whether that, you know, the expectation is that the progression-free survival will be shifted over so they'll have a better progression-free survival than they did in the chorus trial and the URTC trial.
Yes. One question, you have any preference for the PrEP inhibitor and CNS disease? Or if you have a patient with CNS disease, any PrEP, any preference?
Sorry, can you say? I didn't hear it very well. Sorry.
Central nervous system. We have brain metastasis. You prefer wicaparin, niraparin, olaparin for brain metastasis?
Okay. Look, in all honesty, I don't know. I mean, there are some theoretical advantages to using niraparib in brain metastases. I mean, it's said to penetrate into the brain better, but I don't think the data are very solid there. But on that basis, I have tended to use niraparib in the few patients that we've treated who had brain metastases, some of whom had some benefit, some did not. Brain metastases are difficult to treat, you know, anyway. But I've also had actually, well, that was more, I've had some benefit certainly from PARP inhibitors with leptomeningeal disease. That was a patient who received olaparib. So, I mean, a few, but it's a very difficult disease to treat when you've got, you know, brain metastases or leptomeningeal spread.
Yes, because none of the study include patients with CNS disease.
Oh, no, that's right. And, you know, fortunately, it's not very common, but of course it does occur. Yeah, that's right. So, you know, the sorts of, it's case reports that you read, you know, I think we published one with olaparib, that patient who responded well with leptomeningeal disease. You know, they are just case reports, and you know, you have to try and do what you can for these patients, but it's very difficult to treat them.
Okay, Dr. Lederman. Thank you very much for all your knowledge and all your sharing. Thank you for being with us. Gracias a todos los que estuvieron. Esperamos que el Dr. Lederman nos pueda acompañar en persona. Un abrazo a todos y que tengan feliz resto de semana. Thank you, Dr. Lederman.
Pleasure. Nice to see you all. Thank you very much for the invitation. Bye-bye.
Bye. Bye. Gracias a todos. Feliz día.
Feliz día. Muchas gracias.